The Centre presents a new podcast, CBME and You, a podcast devoted to promoting awareness and debate around controversial ethical issues in biomedicine.
Welcome back to CB Me and You, a podcast about biomedical ethics. Today, we talk about birth trauma. What is it? How serious and widespread is it? And what are the philosophical and ethical issues here? So, fun for the whole family. Joining us for today's pod is Angela Ballantyne, professor at the Department of Bioethics at the University of Otago, and good friend of the center here. Welcome, Angela.
Thank you for having me.
I'm so excited to have Angela on the podcast today. One of the few people that can actually keep up with my brain. So bad luck to all our listeners.
Are you trying to compliment yourself here, saying you're so fast or something?
No. I meant
the
you can keep up
scattergun.
with.
Scattergun? Okay.
Thank you. So to get to know you a little bit better, we're going to start off with some questions.
Okay.
Very first one.
All right.
Coffee or copy?
I do like both, but I think I have to go with coffee. I, in my 20s, saw a dietitian in London who deeply critiqued my diet at that point, mainly because of the high caffeine intake and the high sugar intake. Told me to stop both caffeine and sugar, and I thought, well, I can't obviously do both of these, so I cut the sugar out of my coffee.
Yeah.
So now I've got quite used to drinking coffee without the sugar, so I think that's why I find the copy not quite as doesn't hit the spot in the same way.
I kind of imagine a conversation, you're like, your heart is about twice as big as it should be, and you're like, oh, great. No, that's not a good thing.
Yeah, you're twice as manic as you should be. Yeah.
What a fun age in life to go get some advice from a dietitian. That's too much.
Yeah, my sister was working at a company which did sort of, interestingly, biological and sort of biological screening and dietitian advice. So it was, yeah. Anyway, yeah.
I would have.
There's lots I can say about that. Yeah.
Yeah. Okay, moving on.
Yep.
Question 2, what country do you want to travel to next?
That's really tricky. So I'm you're really in the lucky position that I'm just embarking on a 6-month sabbatical. This is day 5. Yes. So that's I'm very spoiled. And there's so many. I was thinking about that question. So many places I'm interested in going. We're going back to Europe, but I think the main thing for me is the people I'm going to get to see. So on the trip, we're going to get to see a few au pairs and nannies that we had for our children who are now back in Europe. So that's in Sweden and France. So that's really lovely. And I'm going to catch up with lots of colleagues overseas who, New Zealand is lovely, but it's very far away from everything.
So far away.
I'm going to get to see Richard Ashcroft, who's one of my PhD supervisors, Jill Craigie, who I did my PhD with in Melbourne, who's now in London. So I think it's really about the people. That's the thing about CBME as well. It's all about the people. So,
Thank you.
Well, now you said back to Europe, so that implies that you used to live there, is that right?
Yes, so I was really lucky. So in my 20s, I lived in Geneva and London for a period and have travelled there, but actually haven't been there for, briefly went there last year, but really not before 2018, so it's been a while. So I'm really looking forward to, getting back.
I think you might be the first person when we've asked this question to who has said, screw the countries, it's the people. I think
that true, though?
That sums you up as a person so beautifully. Final question. No avoiding this one.
Right.
No workarounds. What's your go-to karaoke song?
Yeah, no need for workarounds. I was some thought about the shortlist here. So I think the thing to say about my karaokeing is I love karaoke. I love singing, and I am very, very bad at it. Very bad at it.
Yes! Yeah. We've had many guys who are like, I don't do karaoke.
Oh, you got to go all in, and it's so my husband's a singer, my daughter's a singer, so I'm surrounded by people that can sing well. It's only my youngest child who has really honestly told me, you ruin songs when you sing them. So this is leading. So for karaoke, for me, it's all about the group songs. Then I can sing at top volume with top enthusiasm, but not really inflict my voice on other people. So I think my all-time classic favourite has to be the song that we always finish our karaoke sessions with, which is Total Eclipse of the Heart, which you can do at 110%. Yeah.
Yeah, that's a very good round.
Okay,
good
next
one.
time I come to Otago, I would love to be involved in this
we will
session.
do that, yeah.
We go quite often. I think our next karaoke session is due
soon. It is due. Well, I asked you 2 weeks ago.
I know James had some life events, and obviously how we solve them is karaoke sessions.
Absolutely. Yeah.
There's no other way other than just you
got to sing it out.
Once that's done, you got to sing it out.
But somebody has headaches.
Yeah, I can't leave the house past 10 p.m. at the moment.
I really like an early karaoke session. I feel like it's dark in there. It doesn't matter. Like you start at 6,
You
you're
can do
home
it.
in bed by 9. It's perfect.
Afternoon karaoke can be a thing.
Yeah.
Nobody does it, but it can be a
No.
thing.
Not
it's
gonna lie,
better.
my brain like shut that option off. I didn't know we could do that.
Surprise.
You're on.
The world just got twice as big.
Yeah. Twice as exciting.
Twice as exciting. All right, let's get straight to it. Let's turn around, see what I did there,
I love
and talk
it.
about the serious things. So what is this thing called birth trauma in the first place?
Right. So, birth trauma. So, one of the things that complicates discussions about birth trauma is that it's a recently recognised experience associated with birth, and some of the terminology and language can be a little bit inconsistent. So, if you're looking at the literature, you'll see language around like PTSD, depression related to, so maternal depression related to birth, traumatic birth, birth injury, and depending on which definitions used, they're talking about slightly different things. But broadly speaking now, birth trauma is a subjective experience. So it depends on the woman who is giving birth, how she experiences that. And it's a high degree of anxiety or depression or distress associated with the birth.
How many women or people who are able to give birth experience birth trauma?
Yeah, so the surveys vary a little bit from about sort of 10% to 50%. So on average, a third. So on average, 1 in 3 women experience their birth as traumatic. So that's actually a really high percentage, and continues to be under-recognised in terms of maternity care and clinical care. There's not much, very little screening for it. Of that, so 4% of women have PTSD associated with their birth. So that's more of a clinical diagnosis. That's as high as actually as 19% in high-risk groups. So if you've experienced previous trauma, you're more likely to experience PTSD during birth if you've sort of got that history. So that can include particularly like women that have experienced sexual assault or intimate partner violence. So in New Zealand, 30% of women have experienced intimate partner violence. So if you're coming into birth, which can be a really challenging physical experience and can often involve unpredictability and what women will say is kind of a loss of control over that situation, then those women are more likely to experience PTSD as a result of that. And then sort of slightly associated with that is birth injury, which is a physical injury. So 80% of women experience a birth injury. Some of those, are more minor. So they're your face. Oh, your face. Sinead. So that could include tears, for example, up to more, significant injuries that can have, long-term impacts on health. And then obviously some women experience kind of a psychological or a mental harm associated with the physical injury. Yeah.
Is this purely when we talk about birth trauma, is it primarily a subjective thing? So if a woman feels like she had a bad time and reports some kind of symptoms of PTSD, that is sufficient to count it as birth trauma?
Yeah, so I think that's a really great question to kind of differentiate like a clinical lens and a patient-centered lens. So if you're talking about PTSD, obviously that's a clinical diagnosis. You need a clinician to do that diagnosis. And I think there's been a lot of advocacy from sort of the women's health movement to say, to varying degrees. Some people push back on it more. My position is absolutely, I understand, why you have a clinical lens and clinicians are in charge of diagnostic categories when you can prescribe medication, how you allocate resources. That's not the whole story, right? So that doesn't always completely match on to the woman's internal embodied epistemic experience of birth. So there's been a big push to say actually the people who should define birth trauma are the women. They experience the birth. If they experienced it as traumatic, that's what we should be taking as the baseline and then providing care and treatment according to that.
What you're saying is birth trauma is not an inherent aspect of the birthing process. So what are the key ways in which it might arise or things that women report commonly contribute to experiencing birth trauma?
Yeah, so it's things to do with like helplessness, lack of control and fear. And so there's kind of a range of different things that can lead into that. It can be feeling like they've been disrespected or not listened to. So there's experience of, sometimes this is referred to as like mistreatment during maternity care. So requesting assistance or help, particularly in relation to pain and having that ignored. Experiences of being like belittled or women will say, this doesn't feel right, or I feel like I'm ready to push, and being told clinically, no, that's not the truth, like that's not what's happening. Not having their physical privacy respected, so having people look or touch their bodies in ways where there isn't consent. having people in the room who aren't introduced or who they don't want to be there, and being threatened or coerced into care. So often if you read the narratives, it'll be women are told, if you don't do this, your baby will die. Or if you don't do this, we're not giving you this pain relief. So feeling like really kind of out of control and not at the centre of that care. Women also describe feeling like the clinical team is focused on the health of the baby and that they're just sort of seen as a vessel. And as long as the baby comes out fine, then the birth is kind of recorded as clinically normal, which again just sometimes doesn't match on to the woman's subjective experience of that.
This is really timely because I read the chapter called Birth last night in Margaret Atwood's The Handmaid's Tale. And I found it so interesting, A, how they just remove all medical care, and B, how all the other handmaidens experience like a phantom birth because it's just such like a out-of-body, out-of-world experience, particularly for like just women in general.
Yeah, and that's a good point because whānau, sorry, is a word from New Zealand meaning family. So partners and other family members can also experience birth trauma. So, particularly obviously the partner, if it's a unexpected cesarean or there's like emergency surgical care required, that can be really traumatic for the partner. I have a friend who she was sort of whisked off and the nurse said to the husband, she's not coming back. Meaning she's not coming back to this room, she'll be going to the post-op ward, and then rushed out. But him, in the chaos of it all, thought she'd said she may not be coming back, right? And then was left there for hours, like no one came and got him. So really worth acknowledging that other people involved can experience that. My first birth, I had this really interesting experience with my first birth where I would have said it was just a difficult labour, and I didn't really get involved in the birth trauma space until probably 12 years after that birth. And was invited by a colleague who was founding Birth Trauma Aotearoa, which is a charity in New Zealand, and who wanted me to be involved. And so when I was reading that literature, I suddenly hey, some of these experiences that I had during my first birth match on to birth trauma. One that was really distinctive was disassociating from my body at the end of birth and feeling like I was floating around on the roof watching the end of the process. And so when my daughter was born, she was put on my chest and my mum was shaking my shoulder saying, she's here, she's finally here. And I was thinking, I can't talk right now because I'm not in my body. So I can't make my mouth move because I'm not currently in my body. Now, I just thought, wow, birth is way more intense than I thought it was going to be. And it was only 12 years later reading that literature, I was like, oh, wow, maybe that would actually qualify as a traumatic birth. My sister was there for that birth and said to me, I love you very much and I would do almost anything for you, but I will never, ever watch you give birth again. So your point about the handmaidens, right?
Yeah.
Like being in that room, and it's such an unusual experience. It can have impacts on other people. And also birth trauma, it's worth acknowledging while we kind of talk about, health providers as sometimes in the way they deliver care to women being one of the causes of birth trauma. Often that is because of staff shortages, lack of training and pressure on providers. And traumatic birth is actually really difficult for health providers as well and leads to burnout and staff leaving that sector. So you're right that it can affect other people other than just the woman. Yeah.
So it's both like a structural, it can be a structural problem contributed to by healthcare professionals, either intentionally or, let's be generous,
absolutely,
unintentionally, either staff shortages, etc. But one of the things I'm interested in is, and I sort of get this from my own group of women around me who have had birth or experienced birth, is the way social media contributes to expectations around what birth is going to be, and then because it is social media is not accurate, being incredibly different and significantly worse. And I was just wondering if you're finding that there is research in the way that social media can be really problematic in setting up women to experience birth trauma.
Not in relation to birth trauma specifically, but that's such an interesting question. There's the new Alderman Trust Barometer research, which looks at trust globally, and they did a special report on trust and health that came out this year. And one of the things they found was particularly for younger generations, so kind of 18 to 30, they were really getting their information regarding health from a range of sources. So that was peer-to-peer, either peer-to-peer discussions or kind of Facebook, social media, online influencers, AI-generated health advice, and traditional health providers. So they were using a much greater diversity of sources of health information, which gives rise to more concern about misinformation. So I think you're absolutely right to put your finger on that as a source. I mean, I just think one of the things that I found most interesting after my first birth was just talking to everybody I knew who had given birth and being like, what the heck? Like, what was that? And then everybody just nods and is like, and you say, why didn't you tell me? And you're like, what could I have said? Like, what could I have said that would have explained what that was going to be like? So to an extent, I think in some ways it's unexplainable. So I think the unrealistic expectations are tricky. Or they're impossible to kind of avoid. But that said, I think in terms of preventing birth trauma, there's quite a lot of research that, so there's two things. There's a lack of evidence around pregnancy and pregnancy-related care because we traditionally have excluded pregnant women from clinical research. So there's a lot of, concern that, like for drugs that were released between 1980 and 2000, 91% had no evidence regarding how they impact on the fetus. About 50% of women take medication during pregnancy where there isn't good evidence around health and safety. So this lack of kind of evidence impedes clinicians' ability to provide really good care, but also impedes women's ability to have really good expectations and understanding of that. So that's part of it. Even that said, there's quite a lot of research that shows that too many women go into labour not knowing what to expect, not knowing what the options are, not knowing the risks and benefits of those options. So then when they're in labour, which to be fair is not the best time to be making great decisions. I mean, women can consent during labour. I'm not challenging that.
Just to qualify.
Yeah. But it's not the ideal time to be trying to process all that information. Yeah. So I think, a lot of the literature says that we should be doing more to scaffold women into understanding what those options might be.
It sounds like you're describing a very wide array of of phenomena, I guess. Like you have stuff that starts all the way from, literal physical injury to stuff that might come about due to fear or misinformation. And I'm wondering, what's the drive or what's the motivation for trying to explain all of this using a single lens of birth trauma, as opposed to trying to disambiguate it into different issues and trying to solve them in different ways?
Yeah, no, I think you're absolutely right. So I think what's complicated is there's a lot of, as you're right, background drivers that are sitting there, right? So there's a lack of kind of evidence around maternity care. There's staff shortages. It's hard for women to really understand what labour is going to be like in advance. So all of those things are sitting there. Now, against that backdrop, 1 in 3 women will experience their birth as traumatic. And that's not necessarily predictable in advance, right? So you can have a woman who might look like she's in a vulnerable or high-risk group to start with, who experiences some unexpected complications and the labour clinically seems difficult and actually comes out of it with no signs of birth trauma. And you might have another woman where clinically the clinicians think this actually was pretty straightforward and internally they experience that differently. So I think the thing with birth trauma is a highly activated biological kind of processing of a difficult or challenging event that causes distress. So some people refer to it as being kind of stuck in time. And it can be kind of incomplete. So the processing of that experience is incomplete and it can lead to over-processing. So that would be like flashbacks, nightmares, rumination and anxiety. And it can also lead to sort of disassociation, memory gaps, blanking out. And so because there is an inability to sort of finish the psychological processing, that can become problematic. Now, women who experience birth trauma in that way, you're right that there's degrees of that again, right? So some will be all the way to PTSD and some will just have some of those symptoms, but not all of them. In my case, I think I, in retrospect, processed that simply through I was ruminating. So I would tell the story of that birth again and again and again. And I just was surrounded by enough family and friends that were willing to listen that sort of eventually, processed it through. I think
I almost imagine some of them like repeating some of the plot points for you as you're saying it.
And you're like forgetting some, and then they're like, oh yeah, and then this happened.
And I was just so confused about it. Why did that happen? And then did that happen? And that happened? And then starting again.
And then can you believe the doctor said, we know that.
Yeah. So I think from a kind of health systems perspective, why define it as birth trauma? Because some women do have this high experience of distress. Identifying that earlier and providing some sort of treatment, which might be counselling or more intensive treatment, leads to better psychological and physical outcomes for the mum and also for the baby. So some of the things we see in terms of the impacts of birth trauma are difficulty bonding with the baby, difficulty breastfeeding, difficulty with like intimate relationships with your partner, anxiety, depression, so sort of mental disorders, avoidance of getting pregnant again, which if you're worried about fertility rates in countries might be something you want to look at, fear of childbirth, and then also, this is really interesting from a bioethics perspective, avoidance of healthcare. So because the trauma occurred in a health setting, that can be a triggering event. So it can lead to women either avoiding care in relation to infant care for the baby or for themselves, which leads to health consequences we want to avoid, right? So screening for birth trauma and trying to provide some input in terms of helping women work through that, I think makes sense.
One of the things I'm picking up across a couple of your questions, a couple of your questions and a couple of your answers, is this idea that one of the problems with birth trauma is that we just simply don't have the language to explain what's going on. Like you said, I can't prepare you for it because I don't know how to explain it. And that's a systemic problem. In the literature, I think you refer to this as testimonial injustice, or what's the word?
Hermeneutical.
I've never been able to say that word.
Yeah.
It's like the word restaurant. I can't really spell it. I just sort of avoid it.
All those A's and U's.
Yeah.
Hanging around in the middle. Yeah. I feel you. Yeah.
It's all the ones with like repeating letters for me. Like communication or deterrence.
Oh, yes. I'm really
banana.
feeling this. Restaurant.
Restaurant,
I know.
It took me a solid 20 years.
Yeah.
I'm
there.
Yeah.
I think
okay.
I nailed down necessary while doing my PhD.
Definitely, not defiantly, definitely. I'm glad that we all experienced
So
this.
much commonality.
Okay, but back to birth trauma.
Hermeneutical injustice. Yeah. So Miranda Fricker's work on epistemic injustice, so those are injustices related to knowledge and your capacity to be recognised as a knower, I think are really useful lenses here. So testimonial injustice is when your credibility as a source of knowledge is unfairly downgraded. So what we would say there is when we're belittling or ignoring women when they speak about their own experience during birth, that's a form of testimonial injustice, right? Women are in their bodies, they know what's happening with their bodies, and we should be giving that more weight and credibility than is happening at the moment. Hermeneutical injustice is where you lack a category or language to describe a certain type of experience, and that is unjust because it impedes individuals or groups who experience that from really making sense of their own experience or communicating that with other people. So I find one of the most useful examples for me in understanding what that was the idea of marital rape. So before we kind of had a legal and social concept of marital rape, obviously rape could occur in marriage, but we didn't have any way of explaining that because women were perceived as property of their husband. So rape wasn't something that was recognised as occurring in marriage, which meant that women who were experiencing that were harmed in a way because they couldn't really make sense of it or describe it.
You can't talk about it. You can't get help for it.
Yeah, exactly. Yeah. So I think recent efforts to recognise birth trauma have been helpful in addressing that. Really interesting example from New Zealand. So in New Zealand, we have ACC, which is the Accident Compensation Corporation, which provides no-fault compensation for any injuries you have, including medical injuries.
And this is not just for citizens, right? This applies to even foreigners in New Zealand.
I don't know. That's a good question.
Well, my sister gets it.
Is she a resident though? Or?
Oh, I think she is a resident.
Yeah, maybe for residents.
Okay,
yeah,
okay.
Yeah. But it's generous and it avoids, for example, a lot of issues around like legal liability or suing your doctors for error that occurs during medical care. So it's actually quite a cost-effective, particularly compared to the States, way of dealing with that. So,
But just for our own safety, now if you're thinking of going to New Zealand to give birth, remember, as far as we know, citizens and residents. So it's not going to work. Disclaimer.
Yeah, absolutely. So up until 2022, accident was defined as an injury caused by an external force on the body. So this excluded anyone who was injured during the process of birth because the baby is internal to the body. So there's a lot of advocacy from women's health groups saying, look, you provide all this compensation for medical injury, but for women, giving birth is one of the most dangerous, medical events they'll experience, and women's birth injuries aren't covered. So to make that work, they had to change the definition of injury so that it could include an internal force working on the body causing the injury. So as 80% of women experience some kind of birth-related injury, that's been a really important extension of coverage. But for me, a really interesting idea about like definitions, like, and concepts. So we didn't even, legally recognise those kind of accidents as a type of medical injury in New Zealand.
Yeah.
We might have to cut this, but the first thing my mind went to, because I know both of you, you will appreciate this, is a really explosive poop.
Could you be injured by a really explosive poop?
The man on the pod, everyone. Representation.
Come on, you would have thought of it too. Okay, back to the real content.
We are leaving that in for the second round of this podcast. Yeah, but seriously, couldn't explosive poop be like?
It sounds
I'll ask when I'm back in New Zealand.
a force internal to the body.
Got to call the Prime Minister.
Yeah. I mean, I think the thing with the baby is that the baby can be an object. I don't know to what extent the poop is like is a differentiable object from the body that is currently in you.
An object.
Yeah.
That's so fascinating. People always think that like conceptual analysis, I'm looking at James here, and concepts and definitions plays no weight. You just state what you mean and then move on. But it has a massive impact on the real lives of people out there.
Mm-hmm.
I'm so intrigued that a birth accident, they were like, no, that's the injury that you have experienced, not an injury, it's just part of birth.
Yeah.
And how long in history has this just been how they treat women?
Yeah. And so there's another concept which I think is useful called wrongful depathologization, which is where something should be kind of pathologized, right, and recognized as problematic, but we problematically and wrongfully just say, oh, that's normal. So one thing might be like school bullying, right? Or like initiation ceremonies or hazing ceremonies. It's like, oh, everyone's done that for generations, like, yeah, it's like it's fine. And so birth is often like that. And so, I mean, in terms of kind of questions around like consent and empowerment, research from 2023 in the US has found that 45% of women giving birth in the US don't raise issues with their maternity provider or ask questions when they've got a concern about something for a range of reasons, one of which is that family or friends have just told them that experience is normal, right? So they're not even kind of getting the advice or asking for the information they might need about that because, as you say, it's just classified as, birth is difficult, birth can be hard. And I think that is an impediment to people actually getting the kind of psychological, social and clinical help they might need.
You raised the risk of wrongful depathologization.
Yeah.
But has anybody talked about the risk of over-pathologizing?
Yeah.
I'll
One
get
more
that right. Pathology.
Yeah. So, I mean, that's also interesting in New Zealand. So you get this in the maternity care space, kind of this tension, different philosophies from sort of obstetric care, so gynecology and obstetrics versus midwifery care. So most maternity care in New Zealand is midwifery-led, which is really great in many respects. It leads to a focus on like relationship. So you're getting consistent relationship during the pregnancy and also during the birth and then postnatally for 6 weeks as well. So that relational care is really good. And midwives tend to have, there's big generalizations, but a focus on more natural birth, less technological or medical intervention. So sometimes you get debates between midwives and obstetrics around how necessary cesareans are, for example. At the more dangerous end of that, you can get a focus, I think, sometimes on not getting medical care, or pain relief when actually that's what women need. So, obviously there's always a balance. But yeah, you're absolutely right to point out that you can have problems from over-pathologizing unnecessarily and also from like depathologizing. Yeah.
Well done.
Got it eventually.
So one of the things that seems to be coming out to me is that a lot of this birth trauma can be traced back to the lack of control. And that brings about fear. That brings like undermining a person's autonomy. So and you were talking about we just need to scaffold it better. So how do we scaffold it better?
Yeah. I mean, there's like very downstream things. So I would say like more evidence around pregnancy and care, more evidence around birth trauma. So that we're actually like enabling people to make informed decisions. Even research with health providers, this was a study in Canada, found that a number of health providers so maternity health providers, so midwives and obstetricians, and general practitioners held views that weren't evidence-based. So this might be like having the wrong or having a view about the safety of caesareans that didn't match the data, the safety of home births, the role of doulas in maternity care. So better evidence is one thing. The other is some of those things are around cultural norms in the delivery of pregnancy care. So those things around not listening to women, coercing women, threatening women. I mean, that just absolutely should not be happening. Some of that happens because of staffing levels. So some of that's structural. If we invested more time in maternity care, our staff would be under less stress. And I mean, you made a point earlier about like intentionally or unintentionally. I think that, in my view, midwives are drastically underpaid in New Zealand. There's just been a High Court case that came out 2 months ago where the High Court acknowledged that the government had systematically discriminated against midwives in relation to their pay structure. So I think they're in there trying to do their best. And that those communication things happen either because of cultural norms that are just sort of entrenched and we need to challenge, or largely to do with understaffing. I think the other thing that happens is that people say, well, hey, birth is a bit unpredictable. And that's true, but that doesn't mean that just because, sometimes you need an emergency caesarean, that there aren't other areas where we can really acknowledge women's power and control. So that can be things like talking to women in advance about what they're concerned about, whether they've got any pre-existing trauma or triggers or words, things they don't want to happen. Some women object, for example, for medical students being in the room without their consent. That should be something that's open for discussion. People object to a lot of staff coming in and no one introducing who those people are. That makes the woman feel powerless, and not at the centre of the birth. So there's areas where we can give women more power and control that don't necessarily directly impact on the questions around, like the clinical questions around care. Yeah.
This I haven't obviously had birth because I have no kids, unless you count my cat Chicky, which I do.
Yeah.
But this tracks onto my my own experience of having the intrauterine device inserted.
Mm-hmm.
And so I was not told that there was going to be a man in the room. I'm still not entirely sure what he was doing there other than telling me to eat my jelly beans. And then they humiliated me by not giving me any pain relief other than telling me to have ibuprofen beforehand. They told me it would just be uncomfortable, which evidence shows that many women find it more painful than anything.
Yeah.
And then 3, because the only pain relief I had was to eat jelly beans. I'm not entirely sure what the jelly beans were doing. There was something to do with glucose and preventing me from passing out.
Okay, right.
And that was their main priority, just don't pass out. You can be in as much pain as you've ever experienced in your life, but just don't pass out.
Yeah.
And then I ate all my jelly beans. And then you know what they said to me at the end? You ate all your jelly beans. And I just had to, I have, like, his main job, apparently he was a doctor or maybe the practice manager, was to just tell me to eat my jelly beans.
I think that's so interesting as well, because I feel like I talk to med students a lot. But part of my job is teaching medical students. And one thing I'm always trying to say to them is, I think doctors and health providers often underestimate the power differential between them and a patient. And because of that power differential, statements that they might think are like jokey or lighthearted can really land the wrong way. And a number of women will say, like, I felt judged or like scolded or told off by my health provider. And that can be a real impediment to like going back and a barrier to care.
Yeah.
And I think it's really on health providers to be like very careful, and it's their job to be reading the room about how that stuff's landing.
There was no rapport.
Yeah.
I still don't know his name.
Yeah.
And it's super humiliating. Like, no pants. Like, I'm sitting there with my knees up, I'm bleeding, and they're just telling me to wait another 15 minutes before I can go. And you ate all your jelly beans.
I mean, and the issue of pain is obviously central to like birth, right? And that's the issue around kind of testimonial injustice, because the clinicians can't judge externally how much pain you're in. And so to effectively manage pain, you have to trust what the woman is saying. And have you listened to those recent podcasts, The Retrievalists? So there's 2 podcasts. One was around, the first one is around lack of pain for women undergoing IVF procedures in the United States. And this was at the Yale Fertility Clinic, where they had one of the staff members had been stealing the fentanyl because they had a drug addiction and replacing it with saline. So a number of women who were going through IVF egg extraction procedures were not getting pain relief and were being systematically dismissed as, you're just imagining it. So that was the first series of podcasts. And then the second series is around women experiences having caesareans in the United States and the number who say that the anaesthetic doesn't work. So super interesting, like journalistic bioethics stories. Yeah.
My vindication moment came when a hospital in Victoria has started giving women undergoing the IUD or the green whistle, and I was like, oh, so
Really?
ibuprofen doesn't work? No
That's
way.
interesting.
Yeah. I was like, where was that?
Yeah.
Because I'm absolutely terrified because fortunately for me, when I had mine inserted, it was a 5-year approval in Australia. And then since I've had it, Australia has increased so I don't have to have it out for maybe 7 years.
Oh, right, okay.
And there's a good chance I might not have to have it out for longer than that. And then my doctor told me, like any doctor can take it out. They'll just do it on GP. It'll be about 5 minutes and it's absolutely fine. I was like, you said that when you put it in.
Yeah, and there's a lot
I don't believe you. Like, I don't want to get it out now.
But it's also the variability, right? So it's like, yeah, I mean, again, because there's that variability, you have to trust women in terms of how they're actually experiencing that. Yeah. That pain, yeah.
And obviously mine took like 20 minutes and birth can take hours, days, as some of my friends have told me.
And you finish all the jelly beans in 20 minutes?
20? I was like looking around I was trying to conserve them. I was like, all I can do
I'm rationing them.
Yeah. And then they're judging me for not eating them fast enough. They're like, make sure you eat your jelly beans. Eat your jelly beans. I ate all my jelly beans. And they're like, you ate all your jelly beans.
And where's the evidence? Where's the randomized controlled trial about how many jelly beans someone should consume and in what period?
Give me the packet.
Give me the numbers, averages, means, medians.
So last question. No, moving on from jelly beans. So how do we address this? So when you say like we need to start having conversations, like I hear this, rhetoric a lot. Let's have conversations. How do we have those conversations? Do all women have access to healthcare providers once they become pregnant, or is it just like 3 standard consultations? Like, how can we systematically start to improve the language and share and disseminate this language, particularly to groups of people who experience vulnerabilities or are incredibly high risk, and we know that those are the people that are accessing healthcare the least.
Mm-hmm. Yeah. So, I mean, I think the thing with birth trauma is not all of it's going to be preventable. It's hard to know what percentage is. Estimates in the US, so I mean, again, is like sort of background trends. In the US, maternal mortality has increased from 2018 to 2021, right? So that's a problematic trend, obviously. And about 80% of that is thought to be preventable. So I think a good proportion of birth trauma would be preventable. And I think there's 3 things there. One is staffing levels. One is a change of culture. And that's training for existing staff, medical students, midwifery students around education on birth trauma. And for example, how women experience dismissive care, language, threats, coercion. I think often health providers don't even necessarily realise that that's kind of the culture that they're operating in. The third, I think, would be better standards of consent and trauma-informed care for existing providers. So trauma-informed care is a model that focuses on like safety, choice, empowerment, collaboration, and trust. And so really putting that relationship at the centre of care. So I think you can prevent some. And then I think what you also need is routine diagnostic tests, whether that's a survey or a questionnaire or even someone asking after birth to see if people have experienced birth trauma, and then more accessible and avenues of funding. But women in New Zealand, it's an issue, women who are living rurally and have gone back home, and access to those birth trauma services need to ideally be independent of like the hospital space, so kind of tangential, funded but tangential, because often women won't feel comfortable going back to the hospital if they've experienced more significant birth trauma. So a bunch of it's to do with funding. I mean, there are maternal mental health services in New Zealand. You have to be really, really unwell to access those. And so I think more funding in the maternity space is a critical driver.
Do we have any evidence so far about particular kinds of responses or services are effective at this point?
Yeah, I mean, I think so for more extreme forms like PTSD, there are treatment protocols. You'll probably be seeing a psychiatrist for that. For more moderate to mild forms of birth trauma, even peer-to-peer to support networks can be useful. There's not a huge amount of evidence. I mean, again, often you need the money to do the research for the evidence. So I think more research in terms of understanding what prevents birth trauma and what's effective in treating it would be really great. At the moment, there's high reliance on charities who are just trying to get the services up and running, let alone doing the research around that. So pushing for research is part of that agenda, yeah.
I guess that's another benefit of figuring out what birth trauma is.
Yeah.
And like having that established, because you can put that in a research grant and then like you don't have to say, oh, we're conceptualizing what it is first. And,
yeah. So there's a lot of space, I think you're right, on the conceptual space and in the empirical space to move this forward. Yeah.
One of the questions I have when someone says the word, we need more evidence in relation to pregnancy, is that we have a lot of evidence and pregnant people are trying their absolute best to make sense of it, but it is not consistent. It is not equally accessible. It is often misleading.
Yeah.
But the thing is that we shouldn't be blaming the pregnant person. They are doing their best. They absolutely believe that what they're doing is in the best interest of their child. And so how do we make sure that when we say we need to increase evidence on pregnancy and childbirth, we're doing so in a way that provides clarity and not just more water to the mud?
Yeah, and I think there's quite a sort of there can be quite a paternalistic drive in health promotion and public health, particularly around pregnancy. So women will often say that's the time when they felt like society generally felt most entitled to tell them what to do and how to live.
Did you ever only get little pats on the belly while you were pregnant?
Not so much that. I think maybe I don't give the aura of touch me very much. But I did have, so I got pregnant when I was in the US at Yale, and then we travelled a bit, as responsible parents, used up all the remainder of our funds and travelled for 2 months and got back to New Zealand at 7 months pregnant, which is when I met my midwife, moved into a house and so forth. But I was in Thailand and I had done, as much of the research as I could do about the amount of caffeine I could, going back to caffeine, safely consume during the pregnancy. I knew this down to the milligrams. I knew exactly, how many milligrams were in espresso versus filter coffee versus plunger coffee.
Had a lab set up with a pipette and everything.
Not personally, but I was doing my best, right? And I had ordered a coffee in Thailand and the person who was serving me said, "Oh, you're pregnant. You shouldn't be drinking coffee." And I just thought, do you want to have a conversation with me about how many micrograms of coffee are, in that substance? Was a hidden experience. So through each of my pregnancies, the food that you were allowed to eat decreased. So the list of things that you weren't supposed to eat was getting longer and longer. And during my first pregnancy, I was mainly in bed when I was a postdoc, right? So I was just in bed when I felt sick. So that was sort of manageable. With my later pregnancies, I was working at the med school and had toddlers. So my ability to just rest was significantly impeded. So getting through the day was tricky, right? I had to figure out what to eat, what I could safely eat, when I could eat, how I could manage my energy levels. And so I had this argument around hummus with one of the health providers who said, you can't eat hummus because that's new on the list as a risk of listeria. I was like, so is there any evidence? Like, how many women in New Zealand actually get listeria each year? What proportion of those are hospitalised? What proportion of those have fetal loss or some sort of, miscarriage? And is there any evidence that links how many of those to hummus, right? Like, I don't know, how am I supposed to take this and like actually integrate it into my decision-making in a rational way? And the response was, well, obviously, no, there's not that evidence, but how bad would you feel if you ate hummus and your baby died? So it's two things. It's the lack of evidence, but it's also that paternalistic view that the moralizing around it is like, well, actually, I'd feel like I'd made the best decision I could make in terms of how to balance all the things I had to do that day. And I decided that hummus was a reasonable risk. And if I lost the baby, I'd feel horrific, but I also probably wouldn't feel like that was my fault, right? Yeah. So there's a lot of moralizing, and those are kind of cultural norms around pregnancy as well that are worth challenging.
How dare they come for hummus? I draw the line.
I was like, okay, you've taken my brie, you've taken my camembert.
Excuse you. I was fine with the salmon. I was doing all right with the
Leave me
coffee,
with the hummus.
But the hummus, like, dear God.
Yeah.
This is the hill I will die on. Yeah. And you were in a pretty lucky position in terms of like your ability to question these norms and do a lot of research yourself and all that. I imagine there are lots of women out there who don't have access to kind of, I don't know, social capital to even know how to question doctors and go back and do a bunch of their own independent.
Yeah, that's such a good point, because I think a lot of women's experience of birth trauma is there's a lot of guilt and shame And I think because we're not sort of screening for it and giving women language around it and explaining how, some of the elements of birthing care can result in this kind of fear and hopelessness, and that's kind of, we don't want to say normal and therefore okay experience, but that's an expected experience and we can treat that. Women are left on their own trying to make sense of that. And you're right that, I felt really lucky in terms of thinking back on my first birth that I just was surrounded by, my husband had good maternity leave. He was at home, parental leave. He was at home. I wasn't financially stressed. I had a lot of family around. And so I was able to sort of use those resources that were just socially around me to kind of work through what had been quite a difficult labour. But if women are, don't have those resources, don't have the language, and no one is actively screening them for birth trauma, a lot of women can internalize that and think there was something that they did wrong, that they've failed in some way. And then particularly if that's playing out in terms of them having trouble bonding with the baby, of course, there's a huge amount of guilt around that. If the stress is causing trouble with breastfeeding, there's a lot of shame. And, horrifically, like one of the leading causes of maternal mortality in the first year is suicide. That's just like estimates from 20 to 40% of maternal mortality is suicide. So there's, the mental health challenges for women around pregnancy and caring for a newborn and birth are really significant. Yeah.
And there does seem to be this connection to this wider cultural norm of like putting on women pressure to like do literally everything they can to maximize the outcomes. Mm-hmm. Like you have people, if like a woman doesn't play Mozart to a kid or something, it's like, what do you mean you're not playing Mozart to a kid or something? It's like, dude.
Yeah, and I really felt that as a very sort of over-anxious, overthinker type A parent. I do look back on my parenting of my poor first child. The amount of stimulation that baby got in that first year probably verges on a kind of human rights crime. But yeah, absolutely. There's a lot of perfectionism around that and pressure. And again, like a lack of judging, just giving women the grace of like, trust yourself, right? And trust your instincts here.
That is all we have time for today. Thank you so much for coming on the pod. I hope you enjoy the rest of your time in Singapore. And I look forward to maybe seeing you in New Zealand in July.
Wonderful. Yes. Maybe? Well, no, not this July because I'll be on the other side of the world. But for your next visit, absolutely. Thank you for having me. Thank you for the coffee.
Our pleasure.
And then we just need to sort out the karaoke. And then we're all done.
Oh, hell
Close the loop. Yeah.
All right.
Circling back.
Yeah.
Thanks for listening to our new podcast. Subscribe online and tune in every first of the month. In the meantime, listen to CBME and you and be savvy.